Hi friends, I hope all of you are keeping good. First of all, I would like to say one apology because I could not take classes for you in the last few months because of some personal health issue. Anyway, I hope hereafter I can continue classes for you. Till now, we have completed few antenatal, intranatal and postnatal normal and abnormal classes. So today, I would like to take class about assisted vaginal delivery techniques. As you all know, we have few assisted vaginal delivery technique like forceps delivery and vacuum delivery. Among that, today I will take forceps delivery in detail. First, we'll see what you mean by forceps delivery. Forceps delivery is an assisted vaginal delivery technique in which a pair of metal instrument called obstetrical forceps, which we are applying over the fetal head in order to extract the fetal head during second stage of labor when the mother's effort alone is insufficient or unsafe. Before moving to the forceps delivery in detail, it is very important to understand the parts of obstetrical forceps. Each forceps has blade, shank, lock and handle. In the blade, we have two curves called cephalic curve and pelvic curve. We will see each one of them. First of all, we will see the blade. Blade, we have a curved portion to fit around the fetal head. In case of shank, this is the portion which we can connect the blade to the handle. So next is the lock. This is the area where the two blades articulate. Next will be the handle. Handle is the area which we are holding for traction and manipulation. So I said you we have two curves like cephalic curve and pelvic curve. So here the cephalic curve which fit the fetal head as well as the pelvic curve which fit the maternal pelvis. Next, I will discuss about the types of forceps. We have outlet forceps, low forceps, mid forceps and high forceps. So each forceps has its own criteria to be attained before selecting the forceps. So we will see each one of them. In case of outlet forceps, fetal scalp visible at the introitus without separating the labia. Head on the pelvic floor and it should be rotate less than 45 degree. The example of outlet forceps is Wrigley's forceps. Next is low forceps. Leading point of fetal skull should be at a +2 station or more but not on the pelvic floor. The rotation should be less than or more than 45 degree. The example of low forceps are Simpson's and Elliott forceps. In case of mid forceps, head should be engaged but above +2 station. The example of mid forceps is Killard's forceps. When it comes to the high forceps, these forceps we are no longer performed due to risk. So usually we are using outlet forceps, low forceps and mid forceps depending upon the pelvic and fetal head criteria. Next we will see the indications of forceps application. It can be divided into two, maternal indication and fetal indication. First we will see about the maternal indications. These are maternal exhaustion, prolonged second stage of labor, cardiac, pulmonary or neurological disease where pushing is dangerous and ineffective uterine contraction. Whereas in case of fetal indication include fetal distress which include abnormal fetal heart rate pattern also. After coming head of breech and premature fetus in case we need a gentle extraction in order to extract the fetal head. So these are the indications of forceps application. Before moving to the procedure of forceps application, it is very important to understand the prerequisites. There should be few prerequisites should be attained before the procedure. So these are fully dilated cervix, ruptured membrane, engaged head, exact position of the fetal head unknown, empty bladder and rectum, adequate pelvic space, informed consent or written consent from the mother in order to perform the procedure as well as the anesthesia. Usually we have epidural spinal block and pudendal nerve block for this procedure. Apart from that, a well-experienced operator should be there to perform the procedure. At last, we should have a backup plan for cesarean section if the forceps delivery is unsuccessful. So these are the prerequisites for forceps delivery. Next, we will move on to the preparation. In that, first one is explain the procedure to the patient and we should get the consent from the patient. Next, we have to advise the mother to empty the bladder if possible. Otherwise, we can go for catheterization. The position will be lithotomy position. Aseptic precaution should be taken before, during and after the procedure. Regional or local anesthesia can be given. At last, there will be a vaginal examination to confirm the position and station. These are the preparations before the procedure. Next will be the procedure. We will see the procedure in step by step. First, we have to introduce the blade one by one along the fetal head. First, we have to introduce the left blade, then the right blade. Before introducing the blade, we should insert two fingers into the inserting area in order to create the space. So after that, we can introduce left blade first, then the right blade. After that, lock the blade. Next, we have to check the application whether it is in the correct position. So then we have to apply the traction. The traction should be applied in the axis of the pelvis along with the good uterine contraction. The application of traction should be downward and backward, then horizontal, then upward as the head grounds. We can apply the traction in two ways, like direct traction and rotational traction. In direct traction for outlet forceps and rotational traction can be applied whenever there is a malposition present. Usually we are using Hillard's forceps. Next will be the delivery of the head. The delivery of the head will be slowly under the perineal control. Then remove each blade after the delivery of the head. Next, we have to complete the delivery of the shoulder and body as normal. So this is the procedure for forceps application. Next, we will see the complications. In case of maternal complication, these are vaginal or perineal tear, cervical or vaginal lacerations, postpartum hemorrhage, infection and urinary incontinence, which is very rare. And in case of fetal complication, we have facial bruise or lacerations, cephalohematoma, facial nerve injury, skull fracture, intracranial hemorrhage also very rare. So these are the complications of forceps delivery. Next, we'll move on to the advantages and disadvantages of forceps delivery. First, we'll see the advantages. These are avoid cesarean section, rapid delivery when fetus is distressed, controlled delivery of head, especially in cardiac mothers. When it comes to the disadvantages, these are requires skills and experience, risk of trauma to mother and baby, not suitable if prerequisites unmet. Post-delivery care and nursing responsibility will be displayed on the slide. Please have a look on it. For the exam point of view, this forceps application is very important for the nursing students. I know it is quite difficult to understand if I explain it in a theory way. So for that purpose, I included one video which gives you a clear picture about the forceps application. So I think here we can wind up our today's section. In the next class, we will meet with another episode of midwifery topic. Till that, take care. Bye bye.
Forceps application must be performed by or under direct supervision of an experienced clinician. Before we start, I would like to mention 3 actions you never do. 1. Never apply forceps to an unengaged head. If the head is floating, don't use forceps. 2nd, never apply forceps unless the position of the head is certain. This can lead to very bad fetal injuries. For example, I'll show you quickly here. Example, were you to apply in this position here, whoops, there we go. Were you to apply in this position here, as you can see, you've got the blade directly over the orbit and the eye, which could lead to significant injury, plus these abnormal forces could also lead to a skull fracture. Third, never apply forceps unless the cervix is fully dilated. Applying the forceps to a less than fully dilated cervix can lead to a cervical lacerations. These can bleed heavy. They may be very difficult to visualize if they're high in the vagina and can be difficult to repair. So moving along to the mnemonic, A, 4 components to the A. First, address the patient, explain what you're going to do and get informed consent. Second, make sure analgesia is adequate. This can be either local or regional, for example, an epidural. 3, ask for help. You want more nurses to help with the delivery and with the baby, a pediatrician for the baby, surgery and anesthesia should the forceps fail. 4th, you want there to be an absence of contraindications and its flip side, the presence of an indication. If you place the forceps on without a clear and documented indication, have damage result from the forceps use, you could be held responsible for that damage as you expose the mother and the baby to the risk without a good reason. B, 2 elements to the B. First, bladder empty. A full bladder can actually act as a mechanical impediment to descent of the baby, and also the bladder itself can get damaged. An in and out Foley can take care of that problem. Second element to the B is a backup plan. What are you going to do if the forceps fail? C, 2 components to the C. First, you want to make sure your cervix is fully dilated, your membranes are ruptured, and your head is engaged. Second element of the C is contractions adequate. If your contractions aren't adequate, consider oxytocin. D, 2 elements to the D again. First, determine position. You can do this by ultrasound, so place a transducer just above the symphysis pubis and look for the direction of the orbits. Second, and more commonly, you can do it by palpation. So you want to feel for the triangular shaped posterior fontanelle, and then follow along the sagittal suture when you find it, and find your diamond shaped anterior fontanelle, and the relative position of those can tell you the position of the head. Second element of the D is think dystocia. Any assisted vaginal delivery is at risk of having a shoulder dystocia develop. E. E stands for equipment check. Make sure you've got the proper forceps you're going to need and any equipment to resuscitate the baby. F. F stands for forceps. More than 600 different types of obstetric forceps have been developed over the last 400 years. Their shape is determined by what you want them to do. Obstetric forceps can assist the delivery by doing 1 or more of 4 actions on the baby. First, traction, so you can bring the baby's head down through the pelvis. Second, rotation. If you have the baby's head in a suboptimal rotation, you can use forceps to get it back into OA. They can be also used to flex or extend the head of the baby to ensure that the optimal fetal skull diameters are presenting through the pelvis. So, looking at a pair of forceps, your parts, these are your handles, you've got your lock, you've got your shanks, and these are your blades. This is the toe of the blade. There are 2 curvatures to a pair of forceps. First is the cephalic curvature corresponding to the baby's head. So this one you'll notice is elongated. This is for a molded head. More round is for the an unmolded head. Then you have your pelvic curvature as such. So the pelvic curvature corresponds to the shape of the back wall of the maternal pelvis to allow for to assist in smooth delivery of the head of the infant as such. Good. Okay. So So 4 types of forceps I'm going to mention. First of all are Simpsons, and this is a pair of Simpsons. So Simpsons have got an elongated cephalic curve for a molded head, and they also have the pelvic curvature, so they're used for traction of a molded head, delivering it through the pelvis. Tucker McLean's are similar, except for they have a more rounded cephalic curve. These are Keelan's. Keelan's are used for rotation of the baby's head, so they lack the same pelvic curvature of the other ones. You just rotate the baby's head in place as such. And fourth is Piper's. I don't have a set of Piper's, but they're used for delivery of the aftercoming head in a breech. So prior to putting the forceps onto the baby's head, you want to do a phantom application to make sure they're correctly oriented. So on the outside, just orient them as you think you're going to want them inside the mom. And then you want to take the left handle in your left hand, where the blade is going to go onto the left side of the maternal pelvis. Okay? Get your assistant to hold it for you. And then you want to take the right blade in the right hand. It's going to go onto the right side of maternal pelvis and see if they articulate correctly. Thank you. And as you can see, they have articulated correctly here. I would actually recommend that students do this the wrong way a few times, just to get a sense of how tangled up you can get if you're doing this incorrectly. Okay, so now let's do it on the model. So, again, left blade in my left hand. It's going to go onto the left side of the maternal pelvis. Now there's 2 ways to insert it. The first way, and I'll just mention this briefly, is to bring it in along the direction or parallel to the direction of the inguinal ligament. Won't mention that further. I'm going to describe here the vertical insertion. So you want to hold the blade with 2 fingers as such, or pardon me, hold the handle with 2 fingers as such, and then you place 2 fingers from the other hand deep into the posterior lateral aspect of the vagina, and these fingers are going to both guide the blade in plus protect the maternal tissues. So once you've got it on, you just use gravity to bring the blade around. If you're having to push on the handle of the blade, you may be misapplying it. And once you've got it, feel you've got it in the correct position, you can get your assistant to hold it for you. Now you want to take the right blade in your right hand, and you're going to want to do the vertical insertion. Place your fingers deep in the posterolateral aspect of the vagina, and you bring it down, sweep it around. Thank you. Once you believe you've got it in the right place, you can then see if the blades articulate, and they have. So how do I check that I've got the application correct here? 3 things to look for. The triangular shaped posterior fontanelle should be 1 centimeter or about 1 finger breadth above the plane of the shanks and midway between them. Secondly, the fenestration should be just barely palpable and admit no more than a fingertip. If you can admit more than a fingertip or they're not symmetric, you've got them misapplied. Third, the lambdoid sutures here should be above and equidistant from the blades, with the sagittal suture midway between the blades. Moving on to G. G stands for gentle traction. You only want to exert traction during a maternal contraction when she's actually pushing. The direction of traction will always be in the axis of the pelvic curve at the point of the pelvis where the head of the baby is, and therefore traction will sweep in a J shape. It's going to go in a J shape like this, okay, because that's mirrors the maternal pelvis. Now, Paget's maneuver consists of having one hand pulling on the forceps blade in the direction they're extended, as such, while the other hand pushes down on the shanks at 90 degrees, pushes down on the shanks at 90 degrees to the shanks, so straight down like this, okay? And H stands for hands elevated, so this is following the pelvic curvature. So, mother starts to get a contraction, push, 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 take a deep breath. Push, 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 take a deep breath. Notice how I'm gradually moving the handles in the J shape. Her contraction is gone, you wait, Now, if it happens that the head goes a little bit up in between contractions, that's fine. Just follow it up with a forceps. Wait until she's getting another contraction. Push, 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 push. I stands for incision. That's episiotomy. So if you're needing more room for the blades at some point, you may want to consider an appease. Push, 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 push. Contractions gone. Wait. Contractions coming back. Push, 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 push. J stands for jaw. So you want to remove the forceps when the jaw is visible. So right now, I've got the jaw here. So you want to remove the blades in the reverse order of how they were applied. So the right one comes off first. The left one comes off second. And now you just proceed to deliver the baby as you would. Just before we end, I'd like to quickly show what the blades look like if they're properly applied to the baby's head. Okay. So, that's what it will look like. And as you can see, the toe is not crushing the baby's jaw. The blade is just anterior to the ear and partially overlapping it. Okay. And the cephalic curvature of the blade ends at the parietal bones, right? With the shanks right over the flexion point. And I discussed the flexion point a bit more in the vacuum-assisted delivery. Please also note that the way they're positioned, the widest point of the baby's head is also the widest point of the in between the two blades.